So, everybody welcome. It's April. Next meeting's May. Can I get a motion to approve the minutes for all those who read them? Got a second? All in favor? Correspondence. Columbia EMS Council is advising Greg Fox is replacing Scott Bowman as the Columbia County Remac representative. Also, I'd like to add in that Dr. Taylor Spencer is going to be serving as my alternate, especially since I'm up here in the nights. I want to jump ahead of committee reports. Last time we instituted, or 2 times ago, we instituted the stroke protocol for large vessel occlusions, and we had some discussion afterwards about the timing of at what point do we draw the line for which center we're going to. Looking at the actual Mission Lifeline data, they were recommending 15 minutes unless there's a large distance between centers. And talking about this, I have Dr. Brooks, who's head of neurology from Ellis.
Thank you. You know, we were sort of, I would say, fairly blindsided by this whole issue. And I guess my concern is this. I get all the stroke journals, American Heart Association, Academy of Neurology, and I would open up one of the journals, and for the last 3 or 4 years, they talk about the various protocols and algorithms to screen patients, and it was my understanding that although it would be highly desirable to have an algorithm that was felt to be validated in the field and would separate people with large vessel occlusion strokes from other types of events, it was sort of my understanding that these weren't really ready for prime time yet. All right? And so as I found out about this, I opened the stroke journal, and they have an article that says exactly that same thing, that a lot of these algorithms for triaging patients were evaluated in patients who already were known to have an ischemic stroke, and then they try to differentiate those who have a large vessel occlusion from those who have some other type of ischemic stroke. My concern is if you look at these algorithms, they basically screen out all patients with intracerebral hemorrhages. I mean, most patients with intracerebral hemorrhages clinically will look like somebody with a large vessel occlusion. People with migraine will look like people with large vessel occlusion. People with seizures, patients with functional disorders. And our concern is that, although we clearly want to get patients with large vessel occlusion to a comprehensive stroke center. And Albany Medical Center is a comprehensive stroke patient. We transfer patients all the time. It's a relatively small number of patients, about 1 a week is we transfer. And of those, not all of them end up getting thrombectomy or services we can't provide, but that's fine. So we're talking about a very small percentage of ischemic stroke patients. Ellis Hospital has devoted a great deal of time and resources to developing what we think is a good primary stroke center. A lot of the patients that we see who are in the field thought to have a stroke mimic of various types. Very concerned that a lot of those patients are just going to get shipped elsewhere, longer transport times, and get it sorted out at the comprehensive stroke center. That's not really acceptable from our viewpoint. I mean, the concern is that, yes, those small number of patients will get their intervention more quickly. That's great. But they'll get they very likely will get their TPA, if they're TPA candidates, more slowly. I mean, there's an increased transport time. And I think it's very important to note that they're going to be cared for at an institution where they often don't normally get their care. The records are not available. Their scans are not available. The neurologist that normally cares for them isn't there, which in the nature of these patients is that a lot of them aren't able to give a very detailed history in the emergency setting. So I have some real concerns about this. I mean, we're keeping track of our numbers, and I can't say anything too definitively at this point. I guess this started around January, is that right? Again, my goal is to get the right patients to the right institution. And I have some concerns that this is not thought through, and the consequences aren't fully vetted, let's say. I mean, I'm certainly interested in hearing what anybody else has to say. I don't have all the answers, but, I mean, our institution is really pretty surprised with this.
Discussion or questions, comments?
I mean, I fully realize that if somebody has what looks like a bad stroke on Wolf Road in Colony, and it's equidistant from Ellis Hospital, Albany Medical Center, a pretty good case can be made they should go to Albany Medical Center because they might be one of the few patients who needs intervention. But to take somebody and transport them from Scotia or Galloway or Fulton or Montgomery County, where we get a lot of our patients referred, and bypass our emergency room, we're ready to go for TPA and evaluation. Because in the field, it looked like they might have a large vessel occlusion. I don't totally agree with that.
Yeah.
I think we really have to have something out there for the providers in the field, because like you said, it is terribly confusing. We gotta give them something to go on, and it's never gonna be perfect, but we certainly wanna do no harm. Is there anything in this algorithm that you think could be changed to still leave it useful for the provider in the field, but to address any of those issues?
Well, I guess I would have to look at it in more detail. I guess like using a cutoff of over 3 in the FAST-Ed really basically would include most anybody with an obvious stroke type syndrome. I mean, no, not necessarily brainstem or a cocoon or something like that, but I mean, gee, that's virtually every hemorrhage patient. And you see people all the time that you know, to a non-neurologist or non-trained individual looks sort of like a stroke. So I would have to look at it. The answer is perhaps. I guess if I go over it more carefully, there are, as you know, I'm sure there are other algorithms as well. I mean, I really never sat down and compared one with the other. Maybe there are some tweaks that could be possible.
At Ellis, do you coil for subarachnoids there? Or?
No, subarachnoids we don't do. If somebody
Yeah.
is found to have a subarachnoid, they can transfer.
Okay.
But the thing about subarachnoids is most, I mean.
Not like an intracerebral, right?
Right,
You know,
and it's not like it takes an extra half hour to get to Albany. If somebody's so bad they're not gonna make it to Albany Med, they're probably not gonna make it
Right.
anyway. So it's not like the time is brain sort of thing. No, we don't deal with that.
Got it.
No intracerebral.
Obviously, it's for a relatively small subset of patients, and I'm hesitant to say delaying care because obviously there are things that we can do at Ellis in terms of lytics and things like that for those patients who are candidates for large vessel interventions. But obviously I have some sense anecdotally myself, but do we have an idea of if someone does go to Ellis and is determined to be a candidate for intervention, how quickly our turnaround time is? How much is it, I don't want to say again delaying care, but how much does that add to their
Well, it
their
certainly
time?
adds time. I would say probably about an hour and a half.
Actually, average around an hour and a half, but we've had some cases where they've gone through the whole thing and an MRI 2 hours later shows, oh, they do have something, they're out of the window and maybe they'll benefit. It's really skewed that number. It's really
Yeah.
closer to 45 if you throw the outliers out.
I mean, you know, clearly these procedures should be done as quickly as possible. I will say that, you know, many patients who need thrombectomy will benefit up to 24 hours. I mean, there's reason, you know, if they're selected based on their perfusion scans. So it's not necessarily like if you're beyond 6 hours, you're not going to be a candidate. But it's certainly always going to delay things, you know. And the minimum is probably an hour, and it's usually going to be more than that. But I will say that, I mean, I'm not aware of many patients or any patients that we've had that I thought should have been sent and weren't sent. So the numbers that we're talking about is about 1 a week. And of the 1 a week we send, only about a half end up being candidates for thrombectomy. And that's probably because the vessel opened up with TPA, or what was included is no longer included, or sometimes maybe the damage is too severe. But a lot of times it's because the vessel opened up. So it's you know, kind of a small number of patients. I mean, I don't want to throw away the baby with the bathwater. For those small number of patients, it's an advantage. But the question is, how many patients are going to be deferred outside the institution that they would normally Yeah.
Well, one of the other things is, part of the algorithm is that the drive time can't be more than 30 minutes additional time from the primary to the comprehensive. So a lot of people, west, like Scotia or Duanesburg, the additional time to get to the med is going to be over that 30 minutes. So they're going to fall out and they're going to come to Ellis.
I say even
Because of-
from most of our catchment area,
Yeah.
not, maybe not
Yeah.
Latham, so most of our catchment area, 30 minutes is optimal.
It's 30 minutes.
Right, it's a difference. It's beyond Ellis to
Yeah,
Albany
so here in
Med.
Duanesburg, actually, the difference between getting to Ellis and Albany Med, depending on how close you are to 88, is like 10, 15 minutes.
Right, but, Ellis still is on that. It's close, depending on traffic and other situations. It could be. I don't think it's going to affect the whole Ellis population, but there's certainly going to be a population where still going to Ellis as a primary is going to be within the criteria of the more practical destination.
I find it interesting. This echoes some of the things we were concerned with when we did our initial STEMI destinations. Obviously, Ellis was one of our lead facilities when we were doing STEMIs. And I think for us to make sure that our partner hospitals, and this is me changing hats back and forth really quickly here, but between Albany Med being the comprehensive center and then our partner hospitals in the community that are doing good comprehensive or good primary stroke care, like Dr. Brooks is talking about, is a really important component of this. The thing I think that will help our review of this more than anything else is that all of the partner facilities, with one exception that I know of, across the region, are all doing Mission Lifeline Stroke. And we're doing Mission Lifeline Stroke the same way that we did Mission Lifeline STEMI, is with unblinded data to each other. So that we'll be able to really look at door in, door out times, outcomes, and times inside the facility, time to CT, time to read the CT, time to give TPA, all the things that are important in order to optimize care. I think the fact that we've gotten to a place now where the Heart Association is leading us towards having these comprehensive reviews is going to be important as we continue to evolve here in the Capital District. I definitely recognize Dr. Brooks' concern, and I think the thing that we should really watch for are some of the patients that he's talking about, and we need to do that internally at the Med. As patients come into us directly from Fulton County, to say, really, Fulton County at noon? There's no way this was less than a half an hour farther than Ellis. Fulton County at 3 in the morning? That's half an hour. Rotterdam, it depends where in Rotterdam you are in order to get to the Med, whether it's on that half an hour window or not. But really everything from to the west or the north of Ellis is going to hit that half hour really, really quickly. Most of the other central hospitals in the Capital District are going to be different in terms of that time frame. But watching those times are going to be important. The other thing I think we really have to watch are going to be our fast ED scores on patients that are bypassed from other facilities. As soon as you hit that fast ED score of above 3 or 4 and higher, you're right, the hemorrhagic strokes will fall into that. And there isn't any way for us to pick that up short of having stroke ambulances out there.
Right.
God, let's not go there.
Yeah, no, that's not going to happen. But the concern is, we see somewhere around probably 100 intracerebral hemorrhages a year. That's a significant portion, and most of them come via ambulance. Occasionally somebody walks in, but not typically. That's it's 20% of our stroke patients, where I don't feel there's an overwhelming need to be transferred to the comprehensive center. So that's a concern.
And I think it's the capability of the team at the initial receiving facility is going to make that determination and make that determination based on their own capability, which is very reasonable.
But the problem is we won't get the chance because in the field it'll look like a large vessel occlusion. And
but for folks from the north and the west, you should still get those, and if not, that's a quality issue we've got to work on. I don't know how the natural transfer patterns work. I do know that if I were to look at patients from even the portions of the region we can watch and look what transfer patterns of those patients are in general, to see whether or not it's altering disposition. But I think making sure that we're paying attention to how these tools are being used, making sure they're being used accurately is going to be important.
I'm going to speak for the hospitals to the east, thinking of Samaritan Memorial. If utilizing the scale the way it is, even though from the paramedic viewpoint, we're going to call it a large vessel occlusion, even if it ends up being an hemorrhage, it's still a win. Because Samaritan doesn't have neurosurgery, Albany Memorial doesn't have neurosurgery, so if they got bypassed for the wrong reason and landed in the right place, I'm good with that.
Yeah, and I totally agree. I mean, if there isn't a neurologist on in-house 24 hours a day, 7 days a week, that doesn't evaluate the patient, they don't deal with hemorrhages, you don't know a surgeon, absolutely. See, that's not the situation at our facility. I mean, we have either a neurologist or a neuro-PA in-house 24 hours a day, and there's a neurosurgeon on call every day. And so I totally agree with you, but that's why it's particularly troubling to our facility.
I think what we have to do is look at it from an entire region perspective and collect data, as you say. Although I realize that it's impacting your hospital the most, I'm thinking of all the patients in the entire region, and nothing is going to be perfect, but what's best for the whole region.
The other issue is when patients come to a comprehensive center like St. Peter's, which is obviously right down the road from, or up the road, if you will, from Albany Med. What is the algorithm within the emergency department for a patient that you think may have an LVO, they might not? Are we doing a CT angio before we send them to Albany Med? Are we not doing a CT angio? Because there's a delay there too. And we don't have perfusion scanning at St. Peter's. So that's another interesting part here, a piece of the puzzle. That, and whoever is at Albany Med, we don't know what they're going to say. They might say, we'll do an angio first. That's another, for us, it's like another hour.
I mean, typically they say, don't do it. But, I mean, they add it because of increased radiation and high load. But I would tell you that when the patient, I mean, clinically, as they come through the door, it looks like a large vessel occlusion. The added time to do a CT angiogram is pretty minimal. I mean, they're in the room, you're given a dye, and, you know, you can, I mean, if you do it and there's no large vessel occlusion, the whole issue of transferring the patient is moot.
Right.
And the added time is probably in the range of 5 or 10 minutes. So we can do, but I leave it up to the individual.
Well, I think that what we're going to get here as we look at this data, right, is we may very well end up driving other services that we don't expect. You know, at St. Peter's, where you're waiting for a read from a radiologist, as opposed to at Ellis, where you may be, or you know, one of the neurology team may be reading that CT angiogram primarily. That's going to change the time frame in terms of decision making, and may alter the outcome of how that should be done. And we'll be able to see that as objectively as possible through the Mission Lifeline review. The idea that it's unblinded so we can really look at that and ask the questions will be huge in terms of improving the process.
Yeah, I mean, I think that's the gist of these articles lately, is that they really have to tailor to the particular institution. I mean, I understand we want to have a regional-wide plan, but I would also say that, you know, not all of the different players are exactly equal as far as their ability and their commitment and that sort of thing. So we really have to look at the individual.
No, this is a regional procedure. Regional procedure.
When you say regional procedure, that means it's limited to the Remo region. So anybody west of that, Montgomery County, Fulton County, they're not even affected by this because that's not our region.
They were reviewing it at the last meeting. Actually, were you at the last meeting, Howard? What are they?
The Arams region, the next 6-county region west of us, is under review. This is actually looking at the Remo protocols that have been proposed and possibly adopting them, but they're running into other issues where you know, Ellis very well may be their primary player on the way in, because as you go west of Ellis, there's even less resources as far as neurology goes. So they're really starting to have discussions about aircraft usage, Syracuse, Binghamton, so, yeah.
Any other discussion? amending protocol or leaving it as it is for now?
I say collect data for now, and then put it on the agenda to look at again.
Yeah, because my team are reviewing, make sure they're appropriate, and the travel times.
What I would really love to do would be if we could plan maybe in by September or October, look at all of the data we've gotten so far, invite any of our stroke neurologists to come and join us here so we can look at the picture as a whole from a EMS delivery perspective as well as a stroke perspective and see how we're doing. Would you be willing to come back on?
Sure.
That'd be great. Thank you.
And I think I'll have some more data from our facility too, as far as changes for stroke severity.
That'd be great.
What meeting are you thinking, Mike?
I think will give us enough time. We do it in September, or that's probably right.
That'll give us 6 months and some time to crunch the data from the first 6 months.
Yeah.
Yes, right away to go.
I think it'd be important to get some neurology representation from the outside hospitals.
Agreed. The other thing I'd like to do, and if anybody's interested in partnering, we do have some neurologists that are going to be looking at comparing a FAST-ED score from EMS to a FAST-ED score that's performed in the emergency department and validating that to the NIH score that's done in the emergency department as well. So we can see whether or not we're doing this well.
Yeah, I mean, I think that, you know, in doing some reading about it, it seems like a lot of the validation didn't include people who didn't have ischemic stroke. I mean, yeah, I think it's a reasonable screen for people who look like a large vessel occlusion. The question is, if performed by non-physicians in the field where you could be anything, is it accurate? And I think the specificity is not as good in that setting as it is when you're dealing with somebody who, yeah, had a stroke, isn't a large vessel stroke. So I think that is something. Thank you much. Thank you for letting me come. I appreciate it.
So before I forget, there's an executive session for all the docs afterwards, so don't run away. Committee reports, academic.
Okay, basically, a few things on there. From old business, we discussed a little bit about essential services. You guys remember at the last CMAC meeting, it was brought up, there was a committee formed to look at deciding whether this was a good idea or not. And at least to this point, it was suggested that rather than just saying we need to be essential services, not knowing what that's going to do for us, is start from a clean slate and basically say we need some government agency that will be responsible in every county, municipality to supply emergency services in some form, which would either be they're supporting a volunteer service which exists, a paid services exists, or a municipality. Just so that it basically would sort of form the same model that police and fire have, where there is a government agency that makes sure there is police and there's fire. So more to be said on that at the next CMAC meeting, but I think that's probably the way we're going to go. And then hopefully something will happen at the legislature for that. There's also, if anybody's interested, a list of extended use dates from Pfizer, but only for Pfizer apparently, on their medications that have expired to help with the shortage. If anybody wants to see the list, it's pretty extensive. And if you're interested in doing that, and that's the medications that you have, you need to notify the health department. And that's what you want to do, and the health department will most likely say that's fine. Last, basically, was a nice presentation by Colleen and Mike about using IV nitro instead of sublingual nitro on patients that have CPAP who are in failure. Mike, I don't know if you want to mention something, or Pete, or Paul, she's not still here. You guys want to mention something about it?
Certainly do it now. I don't know how we wake up that projector.
Turn it on.
While Mike's waking up the projector, there are a number of EMT courses that are being
given that Remo with pressures as well, Hudson Valley, and also Cobblestone. And Howard, did you want to mention about the talk that's on April 10th?
Honestly, it sounded like Kevin Robert probably would be better because he's, watch out, there's a bus coming, Kevin. Because he's attended it before, but if you want to speak about the speaker, we're hosting on April 10th. I'm going to say 1 o'clock to 4 o'clock. I'm embarrassed, I can't remember the time, but I'll send it out to everybody and they can distribute it via email. But the speaker is a sheriff from...
Sheriff Whitcomb from Cattaraugus County. It was an amazing talk. He's extremely engaging. He's well-spoken. The material was fantastic. I encourage everyone to go.
And it's basically on first responder trauma, psychological and physical, with response to major incidents. And it's free. And it comes with theme music.
That was awesome. Did we get that on tape?
Sure did.
Thank you.
Can I just back up 1 minute while my brain is still on the stroke thing? As we look at that data, we have to parse it as a whole for the 6 months and then break it up the first 3 months and the last 3 months. Reason being is that was the same time we were ramping up, and our data's gonna be skewed because EMS was not really doing what they're supposed to do, I'm sure, in the first 3 months. So we should compare the first 3, the second 3, and look at it as a whole.
And what it seemed looking at Rotterdam and this team, they are running the scores and they are diverting and appropriate. But that's fine.
Well, that's, you gotta look at both regions.
Can't look at
because our whole presentation is gonna be what is our regional view.
Yeah.
All right, Mike, if you want to just kind of mention that.
Sure. So, Peter, jump in as you want. But SCAPE is actually new and upcoming term for what we already know as many other things. Basically, it's really bad pulmonary edema cases with patients that are profoundly hypertensive and can't breathe. We know over time that these are patients that actually many of our old paramedics learned how to nasally intubate on. These are the patients that would suck in a tube if you held it in your hand on the other side of the room. And these are patients that, frankly, now, through use of aggressive nitrates and CPAP, we're able to manage without intubation, which leads to much better outcomes for them. Let's see if I can actually make this work.
Like now we're going to get into the ER docs yelling at the paramedics for why the hell to bring this person here, whereas we're getting yelled at now by the cardiologist for why the hell you called me.
Exactly, exactly. No matter what happens, we're getting yelled at. So as long as we start there.
But no, we're yelling at them and not getting yelled at.
Right.
You know, we're really in trouble with them.
So I have no idea why this is not there yet. There we go. So current treatment, so CPAP, 12 leads and nitro, that's all very clear. We're there. We know that CPAP takes about 1 to 5 minutes to get maximum effect. That's really when you start getting the pressure in the lower airways that's going to optimize ventilatory support. Unfortunately, we go to give sublingual nitro, and every time we take off that mask, we lose that pressure that we've developed, and we lose the ability to continue to have that improvement. Now, along the way, paramedics have been extremely resourceful. I had one that was suggested using a straw to roll a pill down in order to get it through the hole in the front of the mask down onto the under the tongue. Great idea. The only that's different.
It's better than your screensaver that was rolling by a little while ago.
So this is actually, this is Rich Ruther's Apple TV. We'll have a Remo Apple TV the next time we appear.
Let's see who watches on that. Now we have.
I don't know how we get there because we don't have a remote for this Apple TV. And I don't know why I just fell off it. So let's see if I can get back to that. Yes. We're almost done. And we're back. Yes? No.
Well, no.
I think there's a delay. There is a delay. I don't know why.
There we go. Okay. So current protocol that we wrote back in 2012 said that we were going to use aggressive nitrate 0.4 milligrams sublingual or equivalent. The reason we wrote in or equivalent is because back then, there were people who were already using IV nitro aggressively for treatment of patients that were receiving CPAP, and it did not yet have the ability to get a drip. Scott Weingart in particular writes a bunch about this, and some of the original work that we used to support the idea came from him. The reason that we got to or equivalent was actually through some guidance from Mike. You want to just touch base on bioavailability for a sec?
The bioavailability for sublingual nitro anywhere between 25 to 40%. So I think the protocol you guys went with was 25%, which is very conservative for conversion between sublingual and IV.
So the idea basically being you can always put in more, you can't take it out. So saying that 0.1 milligrams IV was exactly the same as 1 sublingual. So from there, this is the protocol that we already have in place, which is 1 dose of nitro every 5 minutes if the patient's blood pressure is under 160, 2 doses if it's between 160 and 200, and 3 doses if it's over 200. We'll wait that delay, and I have no idea why we have a delay. Sorry.
The electrons have to walk over.
Is that what it is? We'll try it. So 2 slides doesn't make any difference whatsoever. And we fall off again. So we'll do this one more time and then we'll just give up. So reasons to do it, less intubation, fewer days in the hospital, lower mortality. There are a couple of problems. One of them is that IV nitro actually adsorbs to plastic, so it cannot be carried in a plastic bag. It's got to be carried in a bottle. There are a lot of different concentrations of the bottles. The concentration that this protocol or this procedure is put together with is 50 milligrams in 250 mLs. And it's not working with the damn. Yes, here we go. Okay, so here's what we're going to do. Those are the doses based on the 200 mics per ml, which is the concentration. The IV nitro equivalent is 300 mics instead of 3 tablets of 0.4 because of that bioavailability that Mike was just talking about. And this is actually one of the charts developed just to guide people in terms of what they're doing. There are 3 different versions of the chart. Frankly, this is the easiest one to read and think about, keeping it as simple as possible. Goal is to give nitro safely. We'll only use 1 ml syringes, so there's no potential to give larger doses that are appropriate. We will use multiple 1 ml syringes. This is a single patient vial, even though it is 250 milliliters of volume. This will be used on 1 patient and then thrown away. Pricing on this is from $40 and down per bottle. It's not particularly expensive. That's actually about half the price of the nitro spray bottles.
2 hospitals have less than $10.
What was that?
2 hospitals have less than $10.
I didn't hear you.
Less than $10 for 2 hospitals.
Less than $10 if you buy it through the hospital, if that's your source for drugs. And one of the things that we are doing in Colony, and I would recommend to anybody else that would pick this up, is this is a bottle that is glass, shouldn't be carried into the house on a regular basis. Leave it in the truck, wrap it in bubble wrap. There's plenty of bubble wrap available out there. Colony actually has a lot left over from when we used to put it on backboards. So wrap it in bubble wrap, keep it in the truck, and bring it in when you need it. So, thoughts, questions, concerns?
We do need to add it to the formulary so we can vote on that.
Good. Thank you.
Mike, I just want to ask you a question.
Please.
Other Mike Broder.
Much better. I like that much better.
Yeah, you get to slide back in your chair a bit. Don't know if anyone's even looked at this, offhand. I love the whole concept. I think it's great. It's fabulous. The one thing I thought of is concerns of bolus dosing nitrates and what it does to the blood pressure. And we do nitro drips all the time. So I was thinking, how much harder would it be to do a drip We already do drips, we do Levofed, so we have that concept down. Or has there never really been a blood pressure issue with nitrates, in which case this is certainly a lot easier than fumbling with a drip. Every time I order a drip, even if I'm standing next to the paramedic, they go pale. So
I would say drip would add a layer of complexity. This dosing is very conservative based off the information that's out there on the literature. Some folks are using up to 2 milligrams or 2,000 micrograms of nitro, so a lot. You know, the other thing that makes this conservative too is if you take a look at sublingual nitro, bioavailability anywhere between 25 to 40%. If you aim low, we're going to have a lower dose. I'm not familiar with the literature, and I couldn't tell you a specific percentage of we're going to drop blood pressures, but my thought is, given the larger doses that are being given pre-hospital in other systems, that will probably be okay. I wouldn't slam it in, but I would administer it slowly.
I think it's probably safer to go bolus this way, considering we don't have the experience with running the drips, because typically when you get these people on the drip, once they get comfortable, their pressures come down pretty quickly. And this way, since we're not used to that pattern with these patients, then you give the bolus, you're going to check the blood pressure and knows that, okay, it's coming down, you're not going to give the next bolus. Whereas if they're just on the drip, you're going to forget about it and be in trouble.
The drip gives you potential for overdose, whereas as long as you use a 1 cc syringe on this, you have no potential.
right, that's the greatest advantage.
And you can buy a whole bunch of nitro bottles for the cost of a month.
So among the things I'd like to make sure to do with this, first of all, the materials are available for anybody that wants to do it. But I think there are a couple of things that I'd like just some endorsement from this group. The first is anybody that's doing this, I want to make sure that their medical director is on board first. And I'd like that medical director to reach out to me to get the materials so that we can make sure that there's a single point at which we know that all of this is happening. And then every case needs to come through that medical director back to me for review. And I'd like to make sure that we do that through a prearranged system in EMS charts, which will send any IV nitro utilization directly to me. I realize that's going to cause an issue for the few agencies that don't use EMS charts and have made the decision to go in different ways. We'll approach that on a case-by-case basis. So, if this group can endorse that, I would appreciate it.
I make a motion to move ahead with IV nitro for congestive heart failure.
And how about adding IV nitro to the formula?
And adding IV nitro. Yeah, it's hard to give it if you don't have it. Just saying.
Yeah, I guess
Crush it up
that's
and mix it with flush. All in favor?
Aye.
Any opposed? Okay. So then, I guess CMAC was included in that.
Yeah, there's nothing from CMAC at the link company.
Jim Hawk?
Hawk met on March 13th. The vast majority of that meeting focused on the various hospitals reporting on their vulnerability analysis or analyses. Every hospital had the same issues. Every hospital had the same issues. They just ranked them in various levels of importance. You can see on the sheet there from cybersecurity, active shooter was a big one with everybody. Fire, flood, and power failure. Everybody had the same issues, just in different levels. That was basic gist of the meeting. Some upcoming training. Albany Med's hosting BDLS and ADLS as they do every year. And trauma care after resuscitation, if anybody's interested, driving up the Northway to Plattsburgh on May 29th and May 30th. That was it.
No BLS, ALS, first responder upgrades, EPCRs, 5 O'clock, Yoland, Waynesburg, Delmar, Bruin, Wilton, Bolstow, Colony, and Galway are upgraded to Nexus 3.4.
Hey Rob.
Yep.
QI.
Yeah.
Alright, so you were touching on the NEMSIS 3.4, so that was the big thing coming out of QI. There's a list of agencies that Deb has created of EMS chart agencies, EMS charting agencies that need to upgrade to 3.4. To do that, it requires going through your EMS charts rep and making sure that the agency is ready for that update, and then filling out a form 5136. It's a form that everybody should have filled out already, but because there's an upgrade, you have to fill it out again, and then send it to Deb first. Don't send it straight to the state because they need Deb's signature first. So contact your rep, fill out the form, and then send it to Deb, and she'll take care of it from there. She has a bunch of these lists there, so if you need that, talk to Deb, and she'll give that to you. That was the big thing. Continuing projects, CARES is still going on. Art and Paul Segru are working on provider impressions, so there is a big list of provider impressions that Art is trying to pare down, and they're trying to create a way to do that so that there's a more streamlined charting procedure instead of 5 different chest pains, trying to reduce it to maybe 1 or 2. So that's one of the big projects. And then we also spoke about doing a CPR marathon sometime in the fall, with primarily going through 5 Quad, but doing it through the whole region. Just trying to get hands-on CPR and AED education to the community. So we were thinking late August, probably early September. So that would be something in the future that we're going to try to aim to do. So if anybody has some thoughts or would like to help out with that, any help would be greatly appreciated. And then the last thing, pediatric care coordinators. 16 agencies have sent in their applications for a care coordinator. Those of you who haven't, please do so as soon as possible. So that's it. Thank you.
Sorry. Public access defibrillation, PA College Instruction, which is the original upgrade for the prime group, KH Wadsworth Labs, and Department of New York State Department of Labor. New business, we have already covered all of the new business except for with the departure of Dr. Rather, we need a vice chair. Position is for 2 years. If the chair is the Queen of England, nice title, but really no power, the vice chair is kind of like the crown prince. So if anyone would like to submit themselves for consideration, you will probably get it automatically. Anyone want to pad the resume with a nice title? Okay. It seems not here. Who are going to convict an abstention? I'll let that do with people till the next meeting, I guess.
Why don't,
Yes.
just suggest sending an email out to all the members to ask for
We
volunteers.
realized this last time.
What was that saying?
Just send an email out to all the members to ask for volunteers.
And whoever doesn't respond to the email.
Last one.
Last one to say no.
Actually, we should put that, if you do not reply, you will be avoided. Any new business, any other discussions?
I have just an announcement. Not to be an just that the week before EMS week, I believe it's Monday the 13th, St. Peter's Health Partners will be hosting an EMS education night. We're planning on a different venue, not St. Peter's, but potentially Albany Country Club. So.
Will that include a rounding up?
It does not. So more to come on that. We'll send out invites and flyers and so forth. So.
makes? Would you, when that's finalized, would you get that information to me?
Dr. Gill will
I was gonna
Thank you.
email Tim later this week, hopefully.
All right, I'll put it on our
Yeah.
calendar.
So we get, is there anything else?
One more quick thing, there's a lot of muffins back there, and it's a long drive home, so please stop by.
I didn't see them, where are they? You shouldn't have said anything, I would've gotten out of here without them.
And they're really good.
It's unethical to leave her without snacks.
Sorry,
Go out
Sam.
that door, Sam.
Okay, motion to adjourn? Okay. Second. Anybody against? Now remember, we have a executive session. Do we want to use the conference room or we want to continue?
Next meeting, Rob, are we here?
But everybody.